You'll see that I like to be fairly laid back in the way I present things. I want to use these slides for us as a guide point, but what I'd love to do is try to get through them relatively quickly, as quickly as it'll allow us, because I do love the Q&A sessions. I think that is really valuable. It's an opportunity for us to share information and maybe even think about things that were not brought up here on the slides or all the rest. So I do encourage everybody tonight, please get the questions written down, think about it, about things you want to ask me. I think it's a great way to get the conversation going. With that being said, I have the honor to be able to present to you tonight the slides on treating BPH. A little bit of information about me here, so you can see where I was, where I did my training. Some people would say that I like to go to football schools. Louisville was at least one time a good football school, and certainly UF is for a long time in that way. But that's my contact information. You can look at my website for some more information about me if you'd like to know. And as well, my contact number, I apologize, for my office as well. All right, so we're going to go through BPH in order for us to understand what this all means. We sort of need to understand a bit of anatomy. So the picture that you see on the left of your screen kind of shows us the pelvic anatomy. If we look through you, if we cut you in half and look from the side, and up front you see where the bladder is. We see the prostate is the organ that's living right below the bladder. And if you see its relationship to the rectal area, you can then understand why we do what we do when we examine folks when we do our rectal exam. It's because we can feel the surface of the prostate through the rectal wall. The prostate itself is an organ that helps us make our ejaculation more liquid and provides it some nutrients in order to help a woman to get pregnant. That's about the only job it really does. It is what we call an androgen sensitive organ. It grows over our lifetime as a stimulation to testosterone therapy or testosterone just in general. So people may then develop in time one of these things. Now, I say this not because there's, prostate cancer and enlarged prostate and prostatitis are all directly tied into one another, but these are just disease states that can occur to our prostates as we age and, in time. And certainly things like family background, any sort of risk factors like that play a role in this. With prostate enlargement, it is the benign growth in the sense of prostatitis. It's an inflammatory condition of the prostate. And of course, there's prostate cancer, which this talk isn't really about, but obviously things that we have to consider when we're talking to patients. With the BPH, or benign prostatic hyperplasia, it is an enlargement of not necessarily just the entire prostate itself, but actually more specifically an area in the internal part of the prostate in which the lobes kind of kiss against each other, the halves of the prostate kiss against each other and push against the urethral channel. My best analogy that I give patients often is if you can imagine that the bladder and the urethra are like a vase turned upside down, and you take an apple and just kind of shove that vase through the center of the apple. That stem, the urethra, passes through the prostate, the apple. And depending on how big that apple is and how much it squeezes on that stem, it can create obstructive symptoms or urinary tract symptoms. Now, it's important to realize it's not that this is a cancerous growth. In fact, oftentimes people will kind of mistake some of the urinary symptoms they're having with cancer, and it's actually not. Prostate enlargement is, again, almost an inevitability in some of us. So having these symptoms doesn't necessarily tie into actually having prostate cancer. It's just growth of that area that is done so in a benign way that squeezes on that channel. Now, with testing patients, and when we go through the evaluation of, do I think this is prostate enlargement? Is there something else that's there? Of course, we obviously will screen you for prostate cancer along the way, going back to what I said earlier about the finger test, as I like to call it, and also looking at PSA, which is a particular protein that we can measure in the bloodstream that is released by the prostate and can kind of guide us as to the possibility of there being either underlying enlargement or prostate cancer. But again, the degree to which you have urinary symptoms doesn't have to correspond to how big the prostate is. So you can see here in this example, yes, usually there's going to be a global enlargement of the prostate. So there's no question that, typically men will have as an entire organ is larger, but it's really that internal area, kind of where that green arrow is trying to point down on the image on the left-hand side, where it just starts pushing together, causing blockage to the bladder, making it more difficult for you to empty. Now, if you look at the slide, it's a little busy, but if you kind of separate out each one of those boxes, I want to start off by talking about the symptoms that are most directly related to prostate obstruction. Those are called obstructive symptoms: weak stream, maybe straining, hesitancy, dribbling after we're done, things like that. That tends to be mostly a blockage of the prostate, making it difficult for us to empty. But then there's also things like frequency and urgency of urination. So you got to go, I got to go right now. I can't hold it. Sometimes in some men, it may even be leakage or burning when they go pee, things like that. Those are more of what we call storage complaints, which are tied a little bit more into bladder function. So when a patient comes to me, I'll ask all these questions because it does make a difference in how we're going to treat you and the things that we need to consider along the way. Now, if you look, when you kind of ask the average guy, what do you think, about your prostate enlargement? Here's the reality. The reality is, and kind of I always start off with a story like this. I said there's three types of guys. There's guys that come in who say they have no urinary troubles. They probably need to have something done, right? Need to be on medications. There's guys on medications who say, oh, I'm fine, I'm doing great. They probably need to have something done more surgically. And then, of course, there's guys that'll come in asking for surgery, and those guys probably should have had it a while ago. So I use that example because I try to show you that really we sometimes, me included, will sometimes sweep under the rug our symptoms, but in time, when it starts interfering with our life, it's something, it's an everyday thing. And if you can't sleep or whatever the situation is, it's pretty frustrating for guys. Now, I will tell you that the frequency by which this occurs, meaning the actual prostate enlargement, I'll bet you, some of these statistics that are here may be an understatement to some degree. Certainly over time, as we age, we'll see those issues increase in terms of degree and frequency of which they occur. So by our 60s, probably half of us have some degree of urinary troubles related to prostate enlargement. And of course, as we get old enough, then it's almost an inevitability. When we go through this, again, returning back to the slide I said earlier about the obstructive and storage complaints, then I start talking to the patient. I try to figure out, well, where do they live on the spectrum of age, right? What's their age? What's the likelihood that what they're dealing with is prostate enlargement versus something else? And we go through the testing that is normal, including the examination, PSA. Anybody who's online tonight that sees me normally, you'll see I constantly ask what's called an AUA score, which is a great way of keeping track of kind of your impression of your urinary situation. So we'll ask all those things. You may wonder why we measure if you empty or not. Some of us will do a flow test to see your flow, because the whole idea is that we're trying to build a picture as to what's going on with your prostate, and in time, as necessary, start discussing treatments outside of either watchful waiting, as we call it, or medications. So with that being said, what are those treatment options? If you look, most people in the beginning will do what you see on the far left of the screen, which is behavioral modifications, right? I can't tell you how many guys will say, Doc, I waited, I cut out coffee, I cut out sodas, I don't drink as much water, so on and so forth. And all those things are going to work to some degree. They'll usually work towards the urinary complaints of storage complaints, so to speak, but nevertheless, people will usually do that. And it's a great way to help yourself out. But usually we're starting to talk about what are called first-line therapies or interventions based upon the degree of symptoms you're having that are not going to really work quite as well as just the fluid, management and things like that. That's usually either prostate enlargement medications we'll go into more detail, this resume water vapor therapy, or another procedure called urolift, where we use permanent implants to kind of open the prostate area. Again, we'll go through those a little bit more in the next few slides. Surgical therapy, so more invasive surgical therapies include things like the kind of tried and true, what we call the TURP, or what I hear referred to a lot of the Roto-Rooter job. Essentially, we go in and we use a cauterized loop to excise or remove that blocking tissue, almost like a haircut, opening that channel up and allowing you to void better. The choice of surgical energy can differ, so different choices and options. Some people use the traditional TURP with what we call electrocautery energy, but we can also use what's called the green light laser, where we use a different laser technology to help almost evaporate away the tissue as well. Now, I get through my slides here. It froze on me. Okay. I will tell you, it's very important. I get this question a lot. According to our guidelines, I'm not supposed to mention or recommend what are called phytotherapies or phytochemicals, basically natural herbal supplements. We're supposed to kind of steer people away from them. Honestly, I don't completely agree with that standpoint. But to be quite frank with you, I do know that a lot of times those medications, even if they have a placebo effect, are kind of where people will start off with. No, I don't see the major harm in it per se. I don't always recommend it for patients, but certainly if someone is a little bit more trepidatious and worried about actual more traditional therapy, I may talk about it. And as we talked about here, this watchful waiting, we go through here. Most of us are already doing that to begin with, so I'll skip that to the next slide. Alpha blockers. Alpha blockers are very common medications that we prescribe for prostate enlargement issues. In fact, there's a drug Flomax, which I think most of us have either heard of or been on. I will tell you a very interesting story. I think it's worth sharing. Although I don't have the problem of prostate enlargement, I do have something called bladder neck hypertrophy, or a thickening of the bladder opening. And it creates symptoms almost exactly the same as prostate enlargement symptoms. Is interesting because I use, as a urologist, I know what the therapies are. And the first therapy is alpha blockers. And for me, the side effect of what we call orthostatic hypotension, which is drops in your blood pressure if you stand too quickly, were so profound that I took one dose and I couldn't do it anymore. Even though it may have worked on my flow, it was really tough. And I will tell you that one of the fears I have with some of these alpha blockers, some of the older ones called non-selective alpha blockers, have been tied into, believe it or not, coronary congestive heart failure. And the newer medications, there is a question, we don't know quite yet, but there is a question about potential memory issues as well. Now, that's a kind of hot topic that we're discussing in urology today, but there are some concerns we have with those medications, the alpha blockers. Now, there's a different group of medications called 5-alpha reductase inhibitors, and those medications are really designed not necessarily to kind of relax the blockage, which the alpha blockers do, but literally try to shrink the prostate tissue. The medications are effective, believe it or not. You have to take them for at least 6 months before you get good clinical efficacy. So you may be on it for a while without any express a change that you're noticing. But the medications essentially will eventually lead to shrinkage of the prostate, allowing for less blockage. Somewhat on a long-term scale, what the alpha blockers do more immediately. Okay, so the alpha blockers relax small muscles in our prostate, lets us pee better. The 5-alpha reductase inhibitors shrink the prostate tissue over time. Now, personally, I was not inclined to take this medication, and I have the particular reasons are listed to the right. The side effects that are there are bothersome to a good number of people. I'm not a fan of the medication. I will use it in limited clinical applications, but I don't tend to throw that one out at people. And the reason why I say that is because we have other therapies that I think are less hazardous long-term for your body, and more importantly, are more effective than these medications. So the therapy we want to talk about a bit tonight is this resume water vapor therapy. I speak my mind, and I tell you my truth. About 7 months ago, I went to a urologist that specializes in resume therapy, like myself, and got the evaluation. That's when we discussed in the presence of that trouble, my bladder neck hypertrophy. But I went through the evaluation. I know exactly what it feels to be evaluated for the therapy, the look in the bladder, things like that we'll talk about momentarily. But I did so because I believe in this therapy, and I was very much for using that in a way to treat my prostate enlargement. And the way this device works is follows. Very interesting. The device itself plays off of an older technology that was used years ago, called TUNA, or transurethral needle ablation of the prostate, where we used kind of radio frequency waves to warm and kill the prostate tissue. Problem is that therapy was not very effective from a long-term standpoint, and partly it's because it was it wouldn't achieve that kind of symmetrical response in the tissue that we wanted to open the channels up very successfully. So the technology was improved upon. Instead of using radio frequency waves or using pressurized steam, by injecting the steam in that tissue creates a channel over time that allows you to pee better. What that does is a series of what's called programmed cell death, where the cells that are exposed to this heat will die and begin to shrink away the tissue. Now, the advantage of this procedure is that it's minimally invasive, it's office-based, it takes usually a few minutes, even in larger glands where we may need to do more than just a couple of the what I call injections. Even still, these are you're talking about probably less than a couple of minutes. Now, the downside, as you see, there are some side effects, which usually are in the beginning of the therapy. But those are things that long-term will, for most people, will go away completely. The issue of what's called decreased ejaculatory volume or retrograde ejaculation really doesn't happen as frequently as some of the other surgical procedures we'll talk about in a little bit. So the side effect profile long-term is good for this procedure, and it's effective. There's a great little video that I think is worth showing y'all. I'm going to go ahead. There's a little bit of a sound here, but I'll mute it while we're talking. To the left, you'll see what is the diagram of the prostate tissue. We urologists internally kind of joke with the people that make these slides. It's a little bit unclear what's being opened up on the slides, but if you look at the diagram or the actual video, you'll actually see what the long-term goal is, which is by establishing by administering that steam in the tissue, those areas that were treated with the little needle device, those areas will begin to shrink. And it'll do so over time. So it's not an automatic tomorrow kind of thing. It is a progressive improvement in your symptoms. So you'll have to remain on your therapy for at least several weeks, meaning your medications that you're normally on, before we'll take you off of them and see how we're doing. The interesting thing is, as I told you, and I'm being 100% transparent and honest, I promise you, as a urologist, I knew my urinary symptoms. I should have picked up my bladder neck hypertrophy, but I didn't, because you shouldn't diagnose ourselves. I went to a doctor for this therapy. That's how much I believe in it. So if I was going to do it for myself, I would recommend it. My patients, and obviously patients, recommend it to each other. And we'll kind of skip through that testimonial. Now, there's a alternative therapy, this minimally invasive procedure that I'm going to go in briefly on, and that is because I'm not a huge fan of it. And largely it's because it involves placing permanent implants within the prostate tissue. And the reason why I'm not a great fan of this procedure is that the way this device works, almost like a grappling hook, there's a hook that goes on the outside of the prostate wall, and then an internal hook that's exposed to the urethra channel. and it pulls the tissue together. So kind of almost, if you can imagine taking a sponge and just kind of squeezing out all the water. And so what I don't like about that procedure is, again, these primitive implants, that if there's any sort of migration of them, if there's any sort of slipping of those implants, not only can the tissue kind of what we call recur or continue to block you, but occasionally you'll see these devices may actually move outside of just the prostate area and sometimes in the bladder and things like that. So I'm not a huge fan of the procedure, as I certainly, again, looking at what I would do versus, what I would recommend to my patients. When I knew I had urinary troubles, I didn't feel inclined to go for this procedure. Now, if my prostate issues were amenable to this type of things, my urinary issues, I should say, if my prostate was enlarged and probably too large for me to do any other type of minimally invasive therapies, we sometimes use this green light laser and laser therapy to essentially, we talked about the vapor kind of steaming the tissue and eventually opening the channel. Well, this with a heated energy source of this laser will evaporate the tissue while we're watching. Now, the procedure itself, depending on the size of the prostate, can vary in time about how long it takes. It's a surgical procedure that's an outpatient. You're under general anesthesia. So those are some of the downsides of the therapy, relatively speaking. And then, of course, when we see the potential side effects, to be quite frank with you, I think most of those are related to any of the surgical procedures we do and not just exclusive to the green light laser. So I don't really get too involved with saying, well, this is worse than others or better than others. This procedure, what I like about the green light therapy is that it reduces the risk of intraoperative bleeding the way it works. It's effective in our right hands. It's a very good tool for treating prostate enlargement issues. And so there's a great picture here. We'll kind of skip through again. This is a little bit of the fiber or the laser device I actually use. And it emits this green light, or at least looks green to us when we're looking at it in the operating room. And that laser energy, of course, breaks up the tissue, kind of like what we saw with the Resume, but while we're actually doing the procedure itself. And I'll kind of continue on with skip through the animation. In some folks, for whatever the particular reason, if it's surgical, or pardon me, surgeon experience, if it's size of prostate, if there's other mitigating circumstances, sometimes we use that other procedure, the TURP, where we use the loop and we cut open the tissue and we scoop it away. Again, the side effects are very similar to the green lights. It's a general anesthetic procedure. Honestly, most of my patients who do need to get this will stay overnight in the hospital for observation. So unlike the others, it's not an outpatient. It's not a same day type thing. It is an overnight stay at minimum. And then occasionally we get prostates that are so large that doing any of these other therapies is just impossible. We just can't. I always kind of tell the story of someone who's coming into me for a Resume consult, to talk about it. And his prostate, imagine this is a walnut sized organ, right? I mean, not very big. His was about the size of a grapefruit. That literally there was no way to get rid of the tissue that was blocking him without actually doing a more invasive surgical procedure. Different ways to approach it, but basically we call this a simple prostatectomy, where we go in, we leave the prostate there, but we remove the blocking tissue that's causing the problem. That procedure itself technically is the gold standard that we compare everything else to, but it's also more invasive, and we try to really refrain from doing that frequently, although we still do it to this day. It's still a more invasive procedure overall. So we really try to funnel patients into the other less invasive options. Now, oftentimes I get the question of, well, hey doc, is this an elective thing, right? Is this something that I want to do and the insurance companies won't cover it? And the answer is very much, almost resoundingly so. Yeah, it's covered. It really has to do with us and how we work together and coming to the conclusion that we need to do something. So for example, certainly it wouldn't go from, hey doc, I have an occasional dripping after I go pee, to let's do surgery, right? There's going to be things that we go through, document, discuss. But once we've shown that we've worked through whatever we need to work through, you're still having those issues, then yes, there's almost never really any insurance feedback or problems that we get. All right, so the next steps, I apologize, I skipped over that slide. Next steps, if there are people online tonight, of course, again, we're going to do the questions and answers, which I think is extremely valuable. But if there's people if there are people here, they're on tonight, remember our practice has offices across the greater Charlotte metro area. Speak to your physician in the office, ask them about resume therapy. I'm happy to provide this service as well, but there are other physicians besides me that will do resume therapy. Again, I believe in the procedure. I think it's a great option for folks. I think it's better than most of the other things that we talked about, but certainly they can tell you this, whether it's resume or medications or anything else that we need to talk about, it's important first, go to your urologist and just have that frank discussion about what's going on. With that being said, I think we made it through all our slides. I try to be as thoughtful as I could with time. So I'm going to go ahead and open it up to discussions, and thank you for your attention.